Hello everyone. In this video, I'm going to discuss about the management of AML according to the latest ELN 2022 guidelines. Now, management of AML depends on the risk stratification. According to the risk stratification, which is based on the cytogenetics and the molecular markers, the patients AML patients can be divided into favorable risk group, intermediate risk groups, and high risk or adverse risk groups. How to differentiate them into these three groups? That I'm not going to discuss in this lecture. In this lecture, I'll be just focusing on the management. Okay. Now, if the patient is fit, so once we make a diagnosis of AML, then we do the risk stratification, of course, and we'll also assess the patient whether the patient is fit for intensive chemotherapy or not. If the patient is fit for intensive chemotherapy, we'll start with induction regimen, and the most commonly used induction regimen for this kind of patient is 3+7 regimen. What is 3+7? That means 3 days of daunorubicin and 7 days of cytarabine. The dose is cytarabine 100 mg per meter square per day. That has to be given for 7 days, preferably as continuous IV infusion. The dose of daunorubicin is 60 mg per meter square per day for 3 days for the day 1, 2, 3 along with cytarabine, and cytarabine will be given for 7 days. Okay, so cytarabine for 7 days, and the first 3 days we also have to give daunorubicin. Now this is the most common induction regimen that is used. But there are certain other alternative induction regimens, alternatives. These alternatives are used if this 3+7 is not effective or 3+7 doesn't work. So what are these alternatives? These include intermediate dose cytarabine, flag ida. Flag ida means fludarabine, cytarabine, DCSF, idarubicin. Okay. So these are the regimens. Another one more regimen is MEC regimen. This is mitoxantrone based regimen. Mitoxantrone based regimen. Okay, so these are the alternative regimens that can be used. But what else? Apart from that, there are certain add-ons that we have to remember. Add-ons. Add-ons means along with 3+7, we can use these drugs in certain situations. For example, if the patient has FLT3 mutation, FLT3 mutation positivity. Now for these patients, we can use midostaurin. Midostaurin can be used. Midostaurin has increased the 4-year survival by 7.1%. Has increased the 4-year overall survival by 7.1% in patients who are FLT3 positive. Midostaurin is used for patients with 18 to 75 years of age, and it is used as 50 mg BD from day 8 to day 21. So after giving 7 days of cytarabine and along with the initial 3 days of daunorubicin, from the 8th day you can start midostaurin up to day 21. So 2 weeks therapy. So midostaurin is already approved. The other drug for the same indication is being studied is quizartinib. Now the second add-on that you have to remember is GO, that is gemtozumab ozogamicin. GO, that is gemtozumab ozogamicin. Now this is anti CD33 IgG4 antibody, anti-CD33 IgG4 antibody. This can be used. This can be used in patients with core binding factor AML. Core binding factor AML. Core binding factor AML means either having T821 translocation or inversion 16 or inversion 16. If you read the risk stratification, you must be knowing that AML T820 translocation or inversion 16, they have a favorable risk. They have a favorable risk. So gemtuzumab botulinum is used in this group of patients who have a favorable risk. Those are having T821 or inversion 16, and the age group is 50 to 70 years of age. 50 to 70 years of age. This is given as 3 gram per meter square on day 1, day 4, day 7 in the induction, and on day 1 of consolidation. Okay. Now the third add-on that you have to remember is CPX 351. CPX 351. Now this is a liposomal formulation. Of same cytarabine and daunorubicin. The ratio is molar ratio is 5:1. This is used for patients who are mostly therapy related AML or history of MDS bar CMML or AML with myelodysplasia related changes. So basically the secondary AMLs, CPX 351 is used for secondary AMLs. Age group is 60 to 75 years of age. In this age group it is used. Okay, so these are all the add-ons that you have to remember. So along with 3+7, if the patient is FLT3 positive, you can give midostaurin. Remember the age group, that is important. If the patient is core binding factor AML and CD33 positive, core binding factor AML, CD33 positive, you can give gemtuzumab botulinum. And if the patient has secondary AML, that is therapy related AML or AML that has progressed from the MDS bar CMML, in this patient you can give CPX 351. Okay. And these are the alternative induction regimens for fit patients. After giving induction, what is the consolidation of choice? Now consolidation therapy, previously it was very simple. If the patient has favorable risk, then the consolidation is done by high dose cytarabine for 3 cycles. But now they have modified the dose. Now they recommend using intermediate dose cytarabine. That is 1 to 1.5 gram per meter square. 1 to 1.5 gram per meter square BD on day 1, day 2, day 3. Like this, we have to give 3 cycles. So intermediate dose cytarabine is the consolidation therapy of choice for favorable risk patients. The dose is 1 to 1.5 gram per meter square BD on day 1, 2, 3. And we have to give this regimen monthly once for 3 months. That is 3 cycles. But what is the other addition that is given in the newer recommendation is, even in favorable risk, you have to do MRD assessment. At CR1. In the first remission, you have to do MRD assessment. If it is MRD positive, MRD is measurable residual disease. If the residual disease is positive, then you can think of stem cell transplantation also. For intermediate and high risk, consolidation is done by hematopoietic stem cell transplantation at first remission at CR1. Okay. There is one more point that is mentioned. If the relapse risk is more than 35 to 40%, these patients also has to be these patients also you should do transplant. If the relapse risk is more than 35 to 40%, this is mostly applicable for favorable risk patients. Okay, because they have seen that many of the favorable risk group patients also will relapse if they are given only the chemotherapy. If they are managed only with chemotherapy, most of these patients will relapse. That's why now the trend is being more towards hematopoietic stem cell transplantation in AML patients. What else in consolidation? If you have what drugs to be used in consolidation? If you have used FLD3 inhibitors, that is midostaurin or quizartinib in the induction, if you have used gemtuzumab ozogamicin in induction, or if you have used CPX 351 in induction, these drugs has to be incorporated in consolidation also. In consolidation also. Okay. Now coming to the next part, that is maintenance therapy. Remember, in AML, there is no clear-cut guidelines regarding maintenance therapy as compared to ALL. Okay. So in ALL, we will give a prolonged maintenance therapy of around 1.5 to 2 years. But in AML, the concept of maintenance therapy was not there. Now it has been introduced, and according to the FDA, according to FDA, according to FDA, maintenance therapy is known as extended but time limited course of treatment. Basically, the purpose of maintenance therapy is to the relapse, reduce the relapse, and we can use drugs with low toxicity. The drug that is approved is azacitidine. Azacitidine can be used. This can be used as subcutaneous monthly cycles or oral azacitidine. This is a newer addition in the current recommendation. Oral azacitidine can be used as 14-day therapy in a 28-day cycle. And it is preferably used in patients who are more than 55 years of age, and for some reason they are not candidates of hematopoietic stem cell transplantation. In these patients, we can use oral azacitidine as maintenance therapy. Of course, if the patient is FLT3 positive and you have used midostaurin during the induction consolidation, midostaurin can be continued in the maintenance phase also. Now, these whatever we have discussed is regarding the fit patients, the patients who can undergo intensive chemotherapy. But if the patient is not fit for intensive chemotherapy, now what are the options that we have? So, if the patient is older or unfit for intensive chemotherapy due to various comorbid conditions like poor cardiac function, severe infection at presentation, or very poor performance status, we can provide some therapies which are less intensive but somewhat effective. The first regimen that can be used is HMA, hypomethylating agent, plus BCL2 inhibitor, BCL2 inhibitor, that is venetoclax. HMA can be either azacitidine or decitabine. So HMA plus BCL2 inhibitor, plus or minus BCL2 inhibitor. Second regimen is low dose cytarabine plus or minus venetoclax BCL2 inhibitor. Other regimens include low dose cytarabine plus glasdegib. Glasdegib. So glasdegib is sonic hedgehog inhibitor, sonic hedgehog pathway inhibitor. Next, if the patient has IDH1 or IDH2 mutation, IDH1 or IDH2 mutation, you can use ivosidenib. Ivosidenib if the patient is IDH1 positive, or enacedenib if the patient is IDH2 positive. Okay, so these are the regimens that can be used if the patient is older or unfit. Okay, the most commonly used regimen is this one, hypomethylating agent based regimen plus or minus venetoclax. Now coming to the relapsed refractory cases. Now, when do you call a case as refractory? So refractory, what is the definition? If the disease is still persistent after two cycles of intensive chemo, which includes at least one cycle of intermediate dose cytarabine. Now this is very important. Now what does it mean? So if you see the induction chemotherapy, I told you we have to give a 3+7 regimen. Now you are giving 3+7 regimen, then you will assess the response at day 14 and subsequently at day 28. If the disease is still persistent, you will not call those patients as refractory cases. We will not call them as refractory cases. You have to give them a second induction therapy. The second induction therapy can be either 3+7 again, or you can go for intermediate dose cytarabine, or the other alternative regimens that I have already told, either FLAG-IDA or MEC. I hope it is clear to everyone. So if you have started with 3+7 induction, which is the most commonly induction chemotherapy used, then we will assess the response at end of induction. If the disease is still persistent, you will not call those patients as refractory cases. You have to give a second induction. Second induction can be either 3+7 or intermittent dose cytarabine or other alternative regimens like FLAG-IDA or MEC. After giving two cycles of induction chemotherapy, if the disease is still persistent, then only we will call them as refractory cases. And it is always advisable to give the second induction. If you are giving second induction, always give intermediate dose cytarabine, because in the definition they have told that among those two induction chemotherapy, one cycle has to be intermediate dose cytarabine to call it as a refractory disease. Okay, basically the primary refractory disease. I would say this is primary refractory disease. Now for relapsed cases, for AML relapsed cases, what are the pointers that the patient will have a reduced survival? What are the pointers of reduced survival? If it's an early relapse, so early relapse means relapse within 12 months. Other than that, non-favorable non-favorable karyotype, non-favorable karyotype, that is adverse risk patients. Then elderly age, that is around more than 45 years of age, or any prior history of hematopoietic stem cell transplantation. So these are the pointers of reduced survival in relapsed cases. Now therapy regimens that can be used, again you can use HMA plus venetoclax, HMA plus BCL2 inhibitor, that is venetoclax. HMA can be azacitidine or decitabine. If the patient is FLT3 positive, the drug that is approved is gilteritinib. Till now, I was discussing only about midostaurin or quizartinib. Now, but in cases of relapse, refractory cases, gilteritinib has to be used. And quizartinib is under studies, but it has not yet approved. Quizartinib is under studies, showed good response, but not yet approved by FDA or the European agencies. Again, if the patient has IDH1 or IDH2 positivity, then you can use either ivosidenib or inacidenib. Okay. Now, and of course, you can use hematopoietic stem cell transplantation. Of course, you can go for hematopoietic stem cell transplantation. So these are the options that we have in relapsed refractory cases. From all this discussion, you can understand one thing, that at the diagnosis of AML, we must have the cytogenetics or karyotype report, and also you should have the next generation sequencing panel for the molecular markers. Because if you do not have this results of these molecular markers, if the patient relapses or if the patient doesn't respond, we do not have much option to provide. Coming to the last part regarding the allogenic hematopoietic stem cell transplantation. Now, what are the indications of allogenic hematopoietic stem cell transplantation? This I have already told you. Indication is most of the patient with intermediate and adverse risk patient. Hematopoietic stem cell transplantation should be used as consolidation therapy at CR1, and also even if the patient has a favorable risk, if there is MRD persistence like relapse, and they have defined as the relapse risk of 35 to 40%, these patients can be offered allogenic hematopoietic stem cell transplantation. Recuperative regimen, it can be either, it can start from reduced intensity regimen to those myeloablative regimens. Anything can be used based on the individual assessment. Then GVHD prophylaxis, what they have mentioned is post-transplant cyclophosphamide, should be used as GVHD prophylaxis. Then what are the pre and post-transplant strategy to prevent post-transplant relapse? Now what they have mentioned is, after CR1, after remission, use of further chemotherapy, use of further chemo prior to transplant, will not affect the post-transplant relapse, will not reduce the post-transplant relapse. So after CR1, you should not, you should aggressively go for the transplant rather than wasting time in giving more and more chemotherapy. If you are planning for transplant, then you have to take them early, because giving further chemo after CR1 will not reduce the post-transplant relapse. Okay, and patients who are FLT3 positive, who are FLT3 positive. In these patients, post-transplant sorafenib are shown to reduce post-transplant relapse. Okay, so pre-transplant you have to remember, don't give more and more chemotherapy after CR1 thinking that it will reduce the post-transplant relapse. And post-transplant, if the patient is FLT3 positive, you can use sorafenib. It is not budesonide, quizartinib, gilteritinib, it is sorafenib that has shown to reduce relapse. If there is relapse after transplant, then we have very limited option. Sometimes rapid tapering of immunosuppressive therapy along with donor lymphocyte infusion can help. Okay. If the patient is FLT3 positive, relapse cases, we can use gilteritinib. Okay. And other regimen include azacitidine plus donor lymphocyte infusion. These are some of the options after relapse post-transplant. Now, this is in a nutshell regarding the management. Now, in this last slide, I'll just be focusing on some of the important adverse effects of the drugs that are used in patients with AML. Now, we'll start with the induction therapy that we used. I told we are using cytarabine. The adverse effect of cytarabine is chemical conjunctivitis, and cerebellar toxicity. Now, usually these are associated with high dose or intermediate dose cytarabine. The dose that is used in consolidation phase are more associated with toxicity rather than the dose that is used in induction therapy. Induction therapy is we use a lesser dose and usually you don't find any of these adverse effects. But in the consolidation therapy where you use intermediate or high dose therapy, we can find this toxicity. So among them, cerebellar toxicity is important. Daunorubicin, the adverse effect is cardiac toxicity. They'll cause dilated cardiomyopathy. Then FLT3 inhibitors. We'll start with midostaurin. Midostaurin can cause QT prolongation. Gilteritinib can cause QT prolongation, but along with that, they can also cause liver LFT abnormalities and PRES. Rarely, they can cause PRES. PRES is posterior reversible encephalopathy syndrome. So all of this needs dose modification. Then IDH inhibitors. IDH1 inhibitor is ivosidenib. IDH2 inhibitor is enacidenib. Now, ivosidenib can cause differentiation syndrome and QT prolongation. Enacidenib can cause differentiation syndrome and increase in bilirubin. Now, differentiation syndrome we mostly associated with use of ATRA and ATO in patients with acute promyelocytic leukemia. But remember, in cases of AML, these group of drugs, IDH inhibitors, can cause differentiation syndrome. The next one is the anti-CD33 IgG4 molecule, that is gemtuzumab ozogamicin. This is associated with LFT abnormalities and risk of veno-occlusive disease or sinusoidal obstruction syndrome. Okay. So gemtuzumab ozogamicin is notorious to cause veno-occlusive disease or sinusoidal obstruction syndrome. Here, trial of D-fibrotide can be given for sinusoidal obstruction syndrome. Next is venetoclax. This is very important. Venetoclax. Venetoclax can cause severe bone marrow suppression. Severe bone marrow suppression. That's why we need to monitor the counts, and if needed, we have to stop venetoclax for a few days or up to few weeks to allow for count recovery. Venetoclax has a very high risk of causing TLS, tumor lysis syndrome. That's why before starting venetoclax, the WBC count should be less than 25,000. WBC count should be less than 25,000. Now they can have interaction with drugs who can cause CYP3A4 inhibition. So if you are using CYP3A4 inhibitors, for example, ciprofloxacin, ciproflox, or most commonly the posaconazole that you use as antifungal prophylaxis. Sorry, there is a interruption. Okay. So if you are using these drugs, then you have to be very cautious with the dose of venetoclax. Ciprofloxacin is a mild to moderate inhibitor. It's a moderate CYP3A4 inhibitor. Here we have to reduce the dose of venetoclax to 50%. Remember, the venetoclax standard dose is 400 mg OD. So you can use up to 50%, but posaconazole is a strong CYP3A4 inhibitor. In this, the patients who are getting posaconazole, you have to use a ramp up schedule. You have to use a ramp up schedule. That means 10 mg on day 1, then 20 on day 2, 20 on day 2, then 50 on day 3, and then 100 OD. Maximum dose that is advisable to use is 100 mg OD, because of this CYP3A4 inhibitor, they will increase the half-life of venetoclax or increase the duration of action of venetoclax. Other drug is glasdegib, which is sonic hazard pathway inhibitor. They can cause QT prolongation and muscle spasm. Then CPX351, they can cause severe prolonged myelosuppression. Then azacitidine, especially the oral azacitidine, they can cause bone marrow suppression and nausea, vomiting, diarrhea. These are some of the adverse effects that you can remember. Now next we'll just see some of the newer therapies. So newer therapies. Among the newer therapy, the only important drug that you have to remember is CD47 inhibitor. And the drug is magrolimab. The name of the drug is enough, magrolimab. And this is also effective in patients who are having TP53 mutation positivity. Okay. Now the last aspect is supportive care. Special situation and supportive care. The special situation, the first one is hyperleukocytosis, which is defined as WBC count of more than 1 lakh per microliter. WBC count of more than 1 lakh per microliter. For this, we have to use hydroxyurea, and you have to start the induction chemotherapy as early as possible. So start induction chemotherapy as early as possible in patients who are having hyperleuc. Apart from that, you can use hydroxyurea, and you can use leukapheresis if there is leukostasis syndrome. That means there is severe organ involvement in the form of CNS, or most likely the hyperloop. They involve the leukostasis syndrome, usually involve the CNS and the lungs. If there is involvement of these major organs, you can go for leukapheresis. Otherwise, routine use of leukapheresis is not advisable. You have to start chemotherapy, you have to give hydroxyurea. But remember, I told venetoclax should not be started. If you are planning to give venetoclax, it should not be started unless the WBC count has fallen to 25,000. Other situation is like DIC, tumor lysis syndrome, or differentiation syndrome. Remember, the DIC and differentiation syndrome are mostly for acute promyelocytic leukemia, but it can also be seen in AML, and it has to be given according to the standard guidelines. I will not be discussing in details. You have to keep a close watch on the TLS markers. Okay, so the potassium, calcium, phosphorus, uric acid, and you have to monitor the urine output. So all these things you have to take into account, and you have to manage all these things simultaneously along with the disease part. The supportive care, what are the anti-infective prophylaxis? Anti-infective prophylaxis. Anti-infection prophylaxis is variable according to the hospital you are working, according to the prevalent infection in a certain area. What they have recommended is posaconazole. Posaconazole during induction is the antifungal of choice. This is the antifungal of choice. So posaconazole has to be used during the induction because this is the antifungal of choice in AML patients. There is no evidence of using antiviral prophylaxis against herpes or prophylaxis against pneumocystis jirovecii. Okay, so no evidence for using antiviral prophylaxis against herpes simplex virus or anti-PCP prophylaxis. Vaccination has to be given for influenza and COVID-19. Vaccination has to be given for influenza and COVID-19. What about use of growth factors like filgrastim or sargramostim, GCSF therapy? So what is the role? Routinely, these are not used. Routine use is not recommended, so not used routinely. But it can be used if the patient has severe febrile neutropenia, severe febrile neutropenia. Then you can use these growth factors. Okay, so this is in a nutshell regarding the management of AML according to the new AML ELN 2022 guidelines.